welcome to our webinar this evening. Thank you so much for giving your precious time this evening for us to all learn and get better with diabetes management and also learn in this complex situation of both diabetes and COVID how to manage better. For better outcomes. Dr. Vagishire is endocrinologist, professor of endocrinology at St. John's Medical College and also former head of the department over there. And Dr. Vishakha Bansia is an endocrinologist who practices in Cambridge University in UK. And welcome to both of you on this Sunday, May 30th.
Thank you, Seema.
Thank you, Dr. Seema.
I wanted to describe a little bit about our audience. So this is mostly open to all doctors, junior residents, PGs, and all specialists who have now come together to fight this COVID crisis in India. So apart from the practicing general practitioners and family physicians, the nature is that there are so many of our colleagues who are surgeons and specialists and super specialists who are all trying to contribute and do telemedicine and help in this crisis. So I would like to talk to you both today about how to manage diabetes in this situation so that we prevent the severe outcomes that it is known for. As you know, as you all know, 77 million adults in India have diabetes. And the projection is by 2045, we will have 134 million diabetics in India. And wave. And today we have recorded 65,553 cases of COVID-19 infections. And until date, there have been 326,000 deaths. Why is this important? Why is this diabetes and COVID-19 interconnection so important? We have seen with the COVID-19 first wave and worldwide waves that diabetic patients are having more ICU admissions, more percentage on ventilators, and overall severe outcomes in terms of mortality. So this becomes extremely important for us to learn to do better with diabetes management. I want to talk to the panelists about the pathophysiology and the management, but I would like to give each of you a few minutes to please describe your experiences. I would let Dr. Vagishire go first.
Yeah. Ever since corona infection started in India, the first epidemic that last year, we didn't see much cases. The number of cases were less. Though we were very well prepared for it, we started telecommunication, which was not there, teleconsultation, which was not there earlier in India in a big way. It took up in a big way. In fact, our peak cases were 98,000 per day way back in end of September. So afterwards, slowly it came down, but we did have a good number of patients. It reached up to 400 or 450 cases in our St. John's per day. That was the peak number of cases we had in our hospital. Even during first epidemic or a first breakout, people with diabetes had a higher admission to the ICUs, higher admission to the hospital, and also the mortality rate was high in diabetic patient. One of the reason I see is, as such, any hospital admission in across the globe, close to 25% of the patients will be diabetic. That was little more when it came to the COVID. Second thing, there was lab because of the strict lockdown which was imposed first time. Many people didn't come out of the house. Many people started working from the house, so that sedentary lifestyle increased. There was a lot of dietary changes. In fact, that also led to the uncontrolled glucose levels. When they got admitted, the treatment itself made it worse many a times. And when they moved to the ICUs, steroid therapy further complicated, and also the COVID infection worsened, hence mortality rate went up. That is one. Second, as we started seeing patients during COVID admission in the hospital and also post COVID discharge, many had a de novo uh, diabetes. Somebody who were well controlled had a worsening of the diabetes. Subsequently, they required many more medication than what they were taking, and many ended up taking insulin. Then started understanding more and more about the COVID and the diabetes relation. It is like a dual relation. The COVID affects diabetes and diabetes affects COVID. So it has been very well seen that virus replicates in presence of a hyperglycemia, thrives under a glucose media. Hence, the replication and infection increases. One more reason, because of a hyperglycemia, innate immunity is compromised in patients with type 2 diabetes, even in type 1 diabetes. Because we see more and more type 2 diabetes, I think experience will be mainly towards type 2 diabetes. So innate immunity will be compromised. Hence, they are more to develop more pneumonias, more complications than the non-diabetic people. Other thing they have noticed is COVID has a direct effect on the beta cell. So somebody who had a compromised beta cell in patients with type 2 diabetes, their glycemia worsened. And the persons who didn't have a diabetes, at risk of a diabetes, developed diabetes when they got admitted to the hospital. Even a therapy made a difference, especially steroid therapy worsened their glycemia and much more problem to their hyperglycemia and outcome.
Thank you. Dr. Bansia?
Hi, Seema. Just call me Vishaka. Yeah? Makes me very odd.
Vishaka.
You feel very odd when you say Dr. Vansya.
So, Vishaka, you have worked both as an endocrinologist and on the COVID ICU and COVID wards during the UK surge. And we had spoken multiple times on how things were going there. As an endocrinologist, what did you see on the floor, and did you have to change protocols? What changes did you have to make?
Okay. So first of all, just to say, yeah, I did both. Just to give a bit of background, I lead the inpatient diabetes team at the hospital. So clearly my involvement with diabetes during the COVID pandemic was quite significant because we were, the team that was looking after everybody who had diabetes. We do that normally as well. So a couple of things really to note at that point. The first wave, as Dr. Vagish says, actually, even we were prepared for a much higher number of admissions, which didn't materialize. And the second
Vishaka,
wave...
a little louder, please.
Sorry, okay. Can you hear me better now?
Yes.
Yeah, okay, sorry. So the first wave, we didn't get the admissions that we anticipated we would. So that was one thing. And the entire hospital was otherwise cleared out of people who didn't have COVID illness unless they needed to be there. So that did have an impact on diabetes management. You had more staff and more to look per patient to be looked after. The second round, we were completely overwhelmed. So the ICUs were full. A number of the ward areas and theaters had to be converted into ICUs. The staff that were looking after it, you had to draft anyone that who could literally do a blood sugar testing into managing diabetes on the ward. So you had professors who've never seen the inside of a hospital in about 25 years actually on the bedside looking after patients. So that also, we mustn't forget the impact that has on diabetes management. I'm just giving that as a background because that will explain some of the differences, I think, in outcomes when we examine the first versus the second wave. Because staffing and how closely you can monitor someone is very important. So the first thing is that there are some differences, of course, in admission patterns. So in in the first wave in the UK hospitals, only those who were requiring admission were admitted. Initially, pretty much everybody was admitted at least for a couple of days, but we quickly realized the vast majority of them had mild symptoms and could be discharged from hospital. So the people that I saw generally were people who had moderate to severe illness. So they were either oxygen requiring or needed higher level of NIV or intubation. And also, we mustn't forget in the management in the first wave was intubation for a lot of people who were requiring. I think NIV we caught on later on to say that probably is much more beneficial than putting everyone on ventilation. So in the first wave, we had about, I mean, compared to most other hospitals, we probably had fewer. East of England is, particularly Cambridge, is a fairly affluent area, and we do know that the incidence of COVID, etc., is influenced by how deprived your area is, and pretty much there's also a predominance of white population. So again, we know that those from Asian backgrounds, especially relevant to India, would be that they have, the severity of illness is higher in them. So we would say by most other hospital standards, we had fewer admissions. There were 90 to 95 that we looked at in the first wave of ICU admissions for with diabetes alone. And this is not people with pre-existing diabetes, very much as Dr. Vagisha said, that these are patients who had no known history of diabetes. So of the 1995, I can say about a quarter had pre-existing diabetes, most of which were type 2 diabetes. There were only a couple of patients with type 1 diabetes that we admitted in that first wave. And so most of the people who were in hospital had hyperglycemia as a result of the infection, so stress hyperglycemia essentially. Clearly, the people who needed more insulin to manage them were the patients who already had diabetes, and that was almost by 4 or 5 fold the amount of insulin for those who did not have diabetes. And I think the couple of differences that we noticed from what probably Dr. Vagish's experience is actually the incidence of de novo diabetes afterwards wasn't as much as we anticipated. So we analyzed these patients post ICU discharge and post step down from hospital as well into the thing. And we were, I think, out of the 95 that were admitted, 61 survived to discharge and to discharge from hospital. And pretty much only 5 patients remained on insulin. Everybody else came off insulin. And of the 5, 4 were already on insulin pre-admission, just requiring higher doses. And there was only 1 patient who required insulin instead of oral medications on discharge. And that was mainly because they were already fairly poorly controlled. So that is something to look at in the future when we have more number of people to analyze. And there is something called a COVID diab registry that has been started in the UK to follow up long term what would be the incidence of de novo diabetes in those who have COVID. I mean, I'm talking from a fairly small sample size, really, compared to the vast number of people. But that was heartening because we were using quite substantial amounts of insulin in the ICUs to try and manage these people's diabetes. So just to give a little bit idea of the protocol and how we manage diabetes here is essentially everyone pretty much who comes in acutely unwell, especially if they've got risk factors, high BMI, family history of diabetes, or previous impaired glucose tolerance, they will start glucose testing, particularly for the COVID patients. And if the glucose level goes up or bump more than 10, so that's 180 milligrams per deciliter on 2 occasions, at least 4 hours apart. For the COVID patients, we were starting them on IV insulin in the first instance. Most oral medications, were either considered inappropriate, particularly things like metformin, etc., metformin, SGLT2 inhibitors. These were all held on admission. Gliclazide also was held on admission because we weren't quite sure how much the effect would be. And pretty much, anyone who had a stonking hyperglycemia response other than insulin, they would not be controlled. Once they went on to ICU, at that time, the protocols were that they were getting some of the patients were getting steroids. Clearly, unlike the second wave, where pretty much anyone with moderate or severe disease got put on dexamethasone, in the first wave, we were still doing the recovery trials, and the use of steroid was not so widespread. So I think about 50% of our cohort got steroid in one form or another, either methylpred or dexamethasone. And those patients clearly had higher insulin requirements. So everybody who needed it would get started on an IV insulin infusion in the first instance. And as the rates of IV insulin requirements went up, clearly our scales would top off at 6 units an hour. And if the glucose wasn't controlled on that, we would start subcut insulin in addition to the IV insulin. And the subcut insulin usually would be something like Insuletard twice a day, and mostly on a weight-based calculation. So 0.2 units per kilogram of body weight divided into 2 doses would be usually the starting point where people would go from. we had to make differences based on whether they had a pre-existing history of diabetes or not. So clearly, you don't want to give lots of subcut insulin for someone who doesn't have a pre-existing history of diabetes, because what we noticed was that the insulin requirements fall pretty sharply as soon as they started recovering from their acute infection. So if you had lots of high doses of subcut insulin on board, the washout period for that could be up to 24, 48 hours. And we didn't want to push anyone into hypoglycemia. So there was a greater reliance on slightly lower doses of IV of subcut insulin and ramping up of the IV scales to manage with that. People who got steroids, it depended on the type of steroids they got. If they were moderately unwell, not intubated, and they were getting oral steroids at that point, whether that's dexamethasone or in some cases prednisolone was also used initially. The prednisolone profile obviously is quite different from the dexamethasone profile. For prednisolone, you get that sharp rise in glucose if you give it in the morning, by lunchtime, peaking by evening, and then decaying spontaneously overnight. So then the subcut doses would be divided to 2/3 in the morning and 1/3 in the evening. Whereas if you use dexamethasone or methylprednisolone, you fairly get a very flat, high profile, particularly with dexamethasone. And you can almost use twice daily in equal doses with the NPH. Methylpred, the other risk is that it gives an incremental rise in glucose. So first, second, third day, you get kind of additive effect, and your sugar levels keep rising incrementally. So you have to be very much on top of increasing the doses every 24 to 48 hours. Otherwise, you never get on top of that quickly enough. And before you know it, the patient has significant hyperglycemia. Target levels we were aiming for between 6 and 10. So in that would be, I think 6 is what? Is that about 110 milligram per deciliter to 180 milligram per deciliter essentially. And the idea of keeping 6 at the lower was again to sort of give a little bit of buffer between hypoglycemia at 4, which is just under, is that just under 90, around 80, 84, 85. Sorry, I can't convert very quickly between millimoles and milligrams. But that, that is anyway, that is standard hospital inpatient diabetes targets anyway. And we managed, I think we kept pretty much the average glucose for the patients in ICU was between 8 and 10 millimoles per liter, which is between 150 and 180 milligrams per deciliter. That did require quite significant amounts of insulin. So for patients with type 2 diabetes, that could be up to 5 units per kilogram IV. Doses, but for patients without diabetes, that could be quite low, much lower than that. I think the other thing is the choice of steroid was not dictated whether they had diabetes or not. You gave it based on their clinical condition. The only other significant finding we found, which was very interesting, and which is referring back to what Dr. Baghi said about the COVID itself making diabetes much worse. We compared with the historical cohort of patients who did not have COVID, but who had other respiratory infections like influenza, who were admitted to ICU over the preceding years. And what we found was that actually there was, when you matched them for pre-existing diabetes and matched them for other variables such as BMI, there is no difference in the insulin requirements. So if you're severely unwell with a non-COVID respiratory illness or with a COVID respiratory illness, your insulin requirements are pretty much the same. The difference why you feel that they are much more diabetogenic is the sheer numbers that you got with COVID essentially. So it pretty much felt that everyone who was in ICU required insulin. So it felt like there was a uniquely strongly diabetogenic effect with the COVID itself. What did make a difference to whether people required small or large amounts of insulin apart from the pre-existing diabetes status was how much respiratory support they needed. So patients who were on an IV versus patients who were on ECMO versus those who were on proning, those who had epoprostol, on each incremental respiratory support that you had to give, your insulin requirements went up. And we took that to indicate that that was a sort of reflection of the severity of the cytokine storm that you were getting. And we know that those inflammatory, all the inflammatory reactions that you get in any illness increase insulin resistance. So in a way that actually supported the sort of the reverse of how the COVID is affecting insulin resistance and increasing your insulin requirements. And that was completely unanticipated finding, because when we stratified by those, it simply, the insulin requirements just skyrocketed once you required increasing amounts of respiratory support really. And the outcomes correspondingly for those patients were worse as well. So I think in that I'll stop at that, because I think the only other thing I would add was, again, there was a great fear that there would be de novo ketoacidosis and or worsening or lots of DK admissions, and that we might run out of syringe pumps and things like that. Actually, that wasn't borne out. We didn't have that many admissions with DK precipitated as a result of COVID. Now, I can only think of a couple of different things that are not related to the disease itself. Is, of course, management of type 1 diabetes here is slightly different in that pretty much everybody has a ketone meter at home, and there was lots of communication sent out beforehand for patients to make sure that they got enough, made sure they had in-date strips and things from their GPs to make sure they could monitor their ketones at home and practice their sick day rules if they became unwell. So a number of the mild COVID cases, if they did get rising ketones when they were unwell, were able to stem some of that rising ketones by using extra subcut insulin. Now, that again depends on resources and access to what education you've had in the past about managing type 1 diabetes. Some other areas down in London, etc., I did hear that there were higher cases of DK and so on. And again, I don't have personal experience of that, but I didn't see that much in our hospital here. Um, I think the only other thing I say as a primary care issue, and this is in hindsight, is when you follow up patients with diabetes of how they managed in lockdown, it's almost a 50-50 split, in that half the patients felt they actually were becoming more aware of their diabetes and able to manage their diabetes a bit better. They were, because they were at home and they were not rushing around, and they actually could do the things that they're supposed to do. And there was a heightened awareness. Everybody was worried that the mortality rate was higher in patients with diabetes. So they reacted, they changed their self-management for the positive way. They watched their diet. They started doing, they were allowed 1 hour a day outside. So they started doing walks. They started measuring their blood sugar levels. For the other half, it was worsened, partly because of the isolation, partly because they were worried about accessing support. A lot of people, even though we told them they could access help from hospital, chose not to come into hospital when they really needed to come in, especially patients with type 2 diabetes. So that did make a little bit worsened for them. Again, I think this will be over many years that we will find the exact impact of that. Before I go on, just the last thing I want to say is our group also looked at outcomes for type 1 and type 2 diabetes throughout the UK. And this is looking from mortality statistics, essentially. So the differences we found were that there was almost a 3-fold increase in mortality for those with type 1 diabetes and almost a 2-fold increase mortality for those with type 2 diabetes if you got COVID. And the things that made it worse, for example, where one was how well your diabetes was controlled beforehand. So there was almost a 2.2% increase, 2.2 odds ratio if your HbA1c was more than 10% before you had COVID of mortality. And that increased by 1% for every increase above 7.5%, essentially. The second was BMI. So if you had a BMI of about 40, your increase was, I'm trying to remember off the top of my head, but at least about 2 times the risk if your BMI was about 40, but it increased incrementally for every BMI above 30. Surprisingly, people with BMI between 25 and 30 were the ones with the lowest mortality in COVID. And clearly those who had even lower BMI, less than 20, had a much more increase in mortality as well, presumably because of other reasons that are related to their low BMI rather than the diabetes itself. And in terms of death rates throughout at that point, if you looked at the national statistics for the entire UK, there was a 3-fold increase in death rate throughout. And there was a huge spike in overall death rates, which you can only attribute to the prevailing at that point, either to COVID or because, other illnesses were, the primary care and everything was pretty much slowed down at that point. In the second wave when we had the second wave between January and March, COVID-related deaths, diabetes was the most commonly reported comorbidity in those reported COVID-19 deaths. 20% of the COVID-19 deaths had diabetes as a comorbidity, and that's even less than those with Alzheimer's or dementia, which is usually one of the leading comorbidities that is present in usual cases. And in that period when we had a surge in COVID-19 deaths, COVID-19 replaced the ischemic heart disease as the most commonly reported cause of death in that period, essentially. So I'll stop there, and I'm quite happy now to just be directed by what people want to know, rather than say any more. Because, like I said, my experience is pretty much in the UK, and I'd be very interested to see how differently that could be in the US. If I can help you to apply any of this will be great.
Thank you, Vishaka. Dr. Vagish, so I would like to ask you if you had to change inpatient treatment protocols. You're muted. Can you unmute yourself? Thank you.
Yeah, I think pretty similar in lines of what Dr. Vaishaka told. More of a IV insulin use and low threshold to start on the insulin. That was the first thing, is don't wait for glucose to go up for a higher. Low threshold to start insulin. And majority of the OHs were discontinued once the patient moved to the hospitalization, more of a insulin. If they are taking orally, it was more of a subcute in a basal bolus. And if they're in the ICU, it was more of an IV insulin regime. And here, IV insulin is quite liberally we were giving, even we went up to 8 units per hour, 9 units per hour dose based on their glucose, because the corticosteroids, when they are pumped in, the resistance levels was quite high. So more of a IV insulin as long as they were in a ICU setup. Once they are out of ICU, and again they were switched back to the basal bolus subcutaneous insulin.
Seema, you frozen a little bit.
Okay. Asking questions that ICU. Can you hear me?
Yeah, we can now. Thanks. Okay.
Okay. So I have a few questions from management.
Mm-hmm.
Okay. So Dr. Vagish, there were a few questions related to you already answered about the IV insulin versus subcutaneous. That was one of the question. And the other question that they had was if the infusion, switch to infusion in just DKA or even otherwise. That was another question.
Yeah, even otherwise, only without even a DKA or even a ketosis, the preferred insulin therapy was IV insulin in ICU setup. If there is no DKA and all, I think it was mainly a basal bolus subcutaneous in the wards.
Yeah, I think a little bit it will depend upon, also availability.
And one of them, Dr. Punita had a question. Yeah. Vishaka, please go ahead.
Yeah.
Oh, no, I think, Seema, you've got a bit of a lag, so we're just going to have to be patient.
Dr. Vagish? Oh, I'm sorry. Okay. Okay. So the other question is, Dr. Vagish, can you suggest the timing and frequency of capillary blood sugar monitoring in ICU patients? 6 a.m. to 12 noon, 6 p.m. or 11 a.m. samples give more information?
When they were on IV insulin, I think more frequently. In fact, some of the patients, they have done every 2-hour or hourly monitoring to begin with. Once you know the pattern of their glucose levels coming down, the frequency was reduced. So it was more of hourly or 2-hourly to begin with. Then the frequency was reduced. Once it comes to the ward, it was pretty pre-meals and subsequently fasting and 3 a.m.
Okay. And one of the questions were, worse hyperglycemia with, the dexamethasone or methylprednisolone. Which did you see was worse? I mean, Dr. Vishaka has spoken a few points about that. What did you observe?
Most of the patients were on dexamethasone or methylprednisolone. So we had a pretty increase in the glucose throughout the day. It was like a 24-hour profile was on the higher side. So most patient required, like typically when Dr. Vishaka explaining the prednisolone, you require just an NPH insulin in the morning. Rest of the time, you may not require a basal insulin support in the night. But here, throughout the profile was on the higher side. They required twice daily NPH or sometime once daily glargine, which was used. Fine. And boluses with each meal.
Okay, thank you. And
Seema, can I just add
ahead.
one thing to that? Actually, this is something from experience. In terms of choosing which basal insulin, clearly, of course, cost is an issue, and NPH insulin is the cheapest that's available. But if you're looking for analog insulins, one of the other things you observe in anyone who's in ICU is there's a sudden hypoalbuminemia as a result of the inflammation. So an insulin that binds to albumin preferentially, like Levemir, is probably going to be less useful. So if we did want to use an analog insulin, we stuck to glargine rather than Levemir.
Thank you. And what was the target that with the RBS? What was the target, Dr. Vagish, that you tried to achieve?
It's, I think, pretty similar, anywhere between 110 to 180. Try to achieve that range. Probably more closer to 110 when patient is in the wards, while is more conscious and having orally, and between closer to 140 or 180 when patient is in the ICU setup.
Okay. Thank you. And I was trying to divide the inpatient and outpatient category so that we have a clarity on, the guidelines that you are sharing with us. So the next section, we will try to discuss more of the outpatient, what we're seeing, and management. So as you all have seen, doctors, that it's imperative for us to have a better glycemic control in these diabetes patients, because there is increased risk of mortality and severe illness, as both our experts have expressed. Let me ask you, Dr. Vishaka, did you see in your experience that the diabetes patients got COVID more often? I'm talking about the incidence.
So no, I don't think overall we suspected that the incidence was higher. But again, I must say that is modeled by the social circumstances. Over here, what we had was a strict isolation for those who were classed as clinically vulnerable, and that included patients with diabetes. So these patients, so we had the stratification of people who are not to leave their homes. And so, your exposure is considerably less if you have diabetes versus if you don't have diabetes. So I think in the long run, when we look at that data, we may be able to try and tease apart the influence of what we call shielding here, which I don't know if that's the same. I don't think that was stratified so strictly in India. But depending on that, theoretically, there shouldn't be an increased risk of simply catching it, because catching it depends upon exposure rather than any batting away of the virus from entering your air passages. So I don't think just catching it, there should be a difference. Once you catch it, though, your body's response to that, clearly there is a difference in that.
Yeah, I think that's pretty similar, because we saw mainly a diabetic patient rather than the general medicine patient. Probably we had our patients coming with COVID more than the non-diabetic. So it will be totally a bias because ours is a medical school. So otherwise, I think I agree with Dr. Vishaka.
Okay. In US too, we did not see an increase in incidence in patients with diabetes, but it is interesting, though. Probably after the second wave, if we look back on the data, if we can see there was any change in that, because with the hyperglycemia, the viral binding increases and also the viral clearance decreases. So that would probably determine that why they're having a more severe course. But because the viral binding does increase, but still we have not seen any marked increase in incidence of COVID-19 and diabetic patients while compared to non-diabetes. So next, are you seeing patients, new onset diabetes presenting with DKA, Dr. Vagish, in Bangalore?
Less common. I think DKA is pretty less common in our type 2 diabetes, what we have seen. But hyperglycemia with ketosis, just a ketone traces finding it in the urine was more than the ketoacidosis, unless the patient was in ICU for various reasons. They had acidosis and other things. But otherwise, I think DKA was less, more of a hyperglycemia and a ketosis we saw rather than DKA.
Okay. And now we come to how best to manage these patients who are in the outpatient world, because they have less access now coming to the clinics or getting their lab work done, and access to glucometers is not very easy for many of the patients. So these are some of the barriers that I'm sure Dr. Vagish can speak more about. So if you would give us some guidance as to what should we doctors who are not endocrinologists, who are making these phone calls or trying to manage these patients who have already acquired COVID and who are trying to manage their diabetes. Can you speak to that, Dr. Vagish?
By and large, patients who have been in home with home quarantine, that mild COVID patient, we have not made any changes in their management unless their glucometer readings are going high and requiring little and addition of the medications. By and large, mild COVID we have managed like any other patients what we would have managed otherwise. So even the drug medications remain same. There won't be vomiting of any metformin or even a sulfonylureas if they are taking. Same thing was continued. Probably we did a more use of DPP4 on a teleconsult than otherwise. That was the one which was increased much more than, because it was quite safe to initiate and continue compared to the sulfonylurea increment in those patients.
Thank you. And there is some research that DPP4 inhibitors actually is useful in the diabetic patients with COVID. There is some research that shows that the outcomes are better with DPP4. Was that one of the reasons?
That was also one of the reasons, because they are quite safe to initiate. By and large, among all the group of medications, if you see, even if most guidelines you see, there are not much of red flags with DPP4. Otherwise, most medications have a red flags. DPP4 was not having much red flags. That's why it was safely initiated. And you were telling about the safety of the DPP4. I think I happened to go through this month's publication in Lancet by Kamlesh Kunti. If I do, there are two medications which have shown worse outcome. One was insulin, other was a DPP4. It was mainly because more and more they were used. No, this is totally a biased, this one. They have explained also, because most critical patients were on these two medications.
Yeah, that's
Probably
true.
that's the reason the mortality was on the higher side. So this is just because people should not get carried away by that analysis.
I think they didn't find very much to support that theory in the long run, Seema, that DPP4 had any beneficial effect for the COVID. But as you say, when you're trying to manage someone remotely, especially if you're not sure that they're going to be testing their glucose as they should be testing, you will go for a non-hypoglycemia inducing agent as the next line, in preference to something that will drop your glucose. So I suspect that that's the confounding factor, really. The thing to bear in mind, of course, is that DPP4s are quite weak anti-hyperglycemic agents compared to some others. So, you would want to use it where you want a little bit of increment in control. Clearly, if the patient is very out of control, then you would you would want to use something stronger like insulin, even if it's only for a short while. But that comes with the cost of having to educate the patient, making sure they have a glucometer and all of that. So, but that's the benefit versus risk decision that you take, isn't it?
So on the flip side, did you have to discontinue SGLT2 inhibitors and metformin for most patients if they weren't already, but if they were coming to the hospital? Obviously, I think they were taken off. But before that, did you, Vishaka, had you had any concerns with Farxiga and Locana with the DKA issue?
Not for the home patients. Though, of course, all of those on SGLT2s over here, again, we do give them education about ketones. They don't necessarily get a ketone meter, but they're warned that if they get any signs of ketosis, they should seek medical attention because there are just too many type 2 diabetes, and SGLT2s inhibitors are proving to be quite popular drugs. You can't go about getting everybody very expensive ketone meters and ketone strips, particularly, which are the expensive things. But it's about awareness. Clearly, anyone who got admitted to hospital was unwell enough, and therefore, as I said before, things like metformin, SGLT2, sulfonylureas, these were all stopped. Pretty much they all needed insulin, anyone who was admitted.
Okay, thank you. So, Dr. Bagiji, this is specifically now with in India where patients are getting steroids in the kits. You know, they are getting steroids to antibiotics, ivermectin, everything in packaged as a kit in the pharmacies, and patients are starting on steroids whether they need it or not, and this has led to dual crisis. One would prolonging of the viremia because they're taking it within very early on without there is any indication of hypoxia or anything, and the dual problem in diabetic patients, especially hyperglycemia and worsening of the inflammatory markers. So the surge in the pro-inflammatory phenomenon. So what do you suggest in this situation for diabetic patients who are taking steroids with terms of medication dosages or any other guidance that you can give?
Yeah, I think our advice to most of our patients is not to start steroid with OTCs, over-the-counter prescriptions they are getting, not to start the steroids, and to start the steroid only after the prescription from the doctor. But many a times, even a GPs are starting the steroids at the quite early stage. That's true, it is happening because most of the studies showed only two agents showed a lot of improvement. That was one was an anticoagulant, another was a steroids. I think everybody was carried away by that message. But with more and more patients landing with hyperglycemia, hospitalization, and also the mucor cases going up, to some extent, the steroid use has come down. But our suggestion, if somebody on steroids, they end up requiring insulin, and many a times the dosage what they are being prescribing, none of the OHS are going to address their hyperglycemia.
Okay. This is difficult because then if they are monitoring, have you seen that that these patients with steroids are not monitoring as closely and need insulin? How often do you see that?
Most of the patients monitoring frequency is quite less unless they are very well motivated to do that, and they end up in a hyperglycemia more often than not. And even initiation of insulin is quite difficult. If somebody in the family is taking, then the initiation becomes easier, and in isolation nobody can go and give. That is also one of the greatest difficulty in the home quarantine if they are on a steroid we are facing. That's the reason the hyperglycemia toll is quite high in this wave compared to what it was last year.
Okay. So this again is a question more with the access of the glucometer. Our doctors are now seeing patients through telemedicine in rural parts of Karnataka, and they're having real challenges because these patients actually don't have glucometers. So do you have any sort of broad suggestions for us? How could we improve outcomes in this city? There is certainly a barrier for care. Yeah.
I think the only solution is more and more of a awareness and education not to use a steroid unless it has been told or prescribed by a doctor. That is one. Second thing is learning glucometer monitoring is not difficult. Maybe they may have a difficulty first time or a second time. I think subsequently many a times they understand the complexities of testing, and they are quite used to it monitoring. But initially it becomes difficult. And many a times what happens is, even if they measure glucose, they don't know what to do it. Just they record and they tell us in the next consultation, okay, my sugars are all the time, it's higher, what to do. So even if they are measuring, if they are not told how to titrate, it's of again a waste exercise. I think that is what is happening. Everybody is measuring, but they're not acting on the glucose level. That to that extent, it's a quite a big problem, even in a Bangalore.
Okay.
Just they are measured to report you next time when they consult on a video consultation or on teleconsultation.
Okay. We are trying to see if patients are on steroid, then if we can provide some glucometers to PHCs and Anganwadi workers and volunteers, seeing these, making the outreach for these patients to see at least if they can have a random checks, so that we get an idea if there is severe hyperglycemia or if they need insulin or to that effect. But I agree, it is very challenging, even with people who have strips at home, as Dr. Vishaka was alluding to. It's motivation and management. Unless they're on insulin and type 1 diabetes and they are a little bit more motivated, I agree that checks are not happening as it should, or titration is not happening after. Dr. Vishaka, did you have any suggestions? It's more meta, at this stage, because these patients don't, most of them don't have glucometers at home. Or some signs that they should watch out for, or anything that you can give us some.
Yeah, that's the trouble, isn't it, with hyperglycemia? For most moderate
Yeah.
hyperglycemia, you don't get very many symptoms. It's only when things go to an extremist that you start to get the classical symptoms where, you're drinking more and weeing out more and being severely fatigued. And fatigue in COVID is not uncommon as well. So, what you're hoping is people don't get to that stage of extremists before they actually find out they're hyperglycemic. No, it is a challenge, I would suspect, very much in India, where access and strips where people have to self-pay, they're extremely expensive. I think in communities like here in the UK, where they're blessed with a social care system where these are all available for whoever needs it, it's very hard to kind of correlate to that thing. I think awareness is that if you are on steroids at home, then and you have diabetes, then you should be thinking a little bit more carefully about the chances of high glucose, even if it means that you're getting a test in a lab or something just once, just to check where you are. But a single off glucose reading means very little in the context of hyperglycemia, particularly with steroids and so on, and especially if you have no idea of what their previous control was like. Yes, a reliance on symptoms, sadly, that's going to be very hard, just to say whether you are running into trouble or not. Ideally, and again, that's a difference between the management of COVID between India and here. I mean, pretty much anyone who needed steroids here for their COVID would have been in hospital, because they would have been classed as moderately unwell. You do not give steroids for those who have mild diabetes, mild COVID. But that is again a reflection of the health system rather than the illness itself. So my experience would be practically zero in that, because like I said, steroids at home, the only people whose experience we have are the ones who are on steroids for other reasons, lung diseases or part of inflammatory diseases like any other inflammatory suppression and so on. And those people are often, because they're on longer term steroids, have already been seen in outpatient clinics or in GP practices and been given with a glucometer and been given medications to address depending on the profile of the steroid that they are on. So de novo putting someone on steroids at home, that is highly unusual. So it's not something that I would but that happens here as well, to be honest with you. When people start on short courses of steroids for COPD, often that connection between steroids and hyperglycemia is not made. So we do catch people, who have been taking steroids in the community, who have been happily been hyperglycemic without realizing it. In the context of COVID, obviously, that does make outcomes much worse. So, you do want to catch it. I don't know the solution for that, to be honest with you. As long as you've got steroids in the community with poor access to glucometers, you have a huge problem.
Thank you. Dr. Wagi, some of the doctors were asking what are the main brands of the DPP-4 that are available in India. Can you please speak to that?
Yeah, I think we have got vildagliptin, which is generic now. It's almost the cost of the medication is equivalent to a glimepiride or a glyclazide. Almost the cost of the vildagliptin, and it's available in combination with metformin also. That is very widely used DPP-4 now. Before vildagliptin became generic, I think teneligliptin was the one which was used widely. This teneligliptin doesn't have much presence in Europe and America. It has got mainly presence in Asia, that too Japan, Korea, India, and China, mainly Asian countries. That was widely used because it was off patent. And from 2014 or 15, we were also involved in the phase 3 clinical trial of that teneligliptin. It was widely used. From last 2 years, vildagliptin has been widely used because of suddenly it became a generic, and about 100 200 companies are producing vildagliptin, quite cost effective compared to the original brand. It is almost 20% of the cost of original vildagliptin. So that is why commonly used vildagliptin. Next will be the teneligliptin, that is available in 20 milligrams. Most of the time we'll be using once, rarely on the twice daily basis. Rest of the gliptins are quite expensive. The sitagliptin is available, is almost close to $1, 50 rupees. And we have got, we don't have alogliptin here. That's the one which is not available. Sita, Vilda, and the teneligliptins are widely used.
Okay, great. And a few, there are widely available glucometers of different brands. Do you have any recommendations on some of the good affordable brands of glucometers?
Yeah, I think Roche's AccuCheck is available. It's a bit on the expensive side, but from past 10 years, only in India one came, One Touch we call it as. It's available at 1,000 rupees. Even the strips are at the cheaper rate compared to the AccuCheck, Roche's AccuCheck. I think One Touch is one closely reliable, as good as your AccuCheck from Roche.
Okay, wonderful. Thank you. And one question, Vishakha, have you seen worsening of hypothyroidism in patients who have both diabetes and COVID-19?
I don't think that's a good question. I can't answer that. I have absolutely not paid any attention to the thyroid function in the patients with COVID, and nor have I read up anything about it. So sorry, I can't answer that question.
That's okay. It was a question from Dr. Here.
I'd be interested to hear why that question came up, though. Has there been any experience with that? I certainly can go back and look.
I think they were worried about, I don't know, maybe with the Dr. Punita, I will ask her after and see why she was thinking on those lines, because I haven't seen that. And for
Dr. Wagish, your experience with hypothyroidism?
I have not, I think, looked keenly into this data, but by and large, I have not seen much change in their medication. It's almost pretty same. We have not seen any new onset thyroid cases or anything special following COVID. We have not looked keenly into it, but by and large, not great increase in the surge in the thyroid patients, because the follow-up, if somebody is very well controlled, follow-up is once in 6 months or a year. That's why I think it will take a much longer time to reflect the change.
Thank you. So my next question is with the, again, coming back to the elephant in the room, the steroids. So if in case they do end up on steroids, prescription, I'm talking about, if their, inflammatory markers are high, or if their CT is showing some worsening changes, mildly hypoxic, and they're started on home steroids. What do you recommend in terms of changes in the dose of the diabetic medications, if at all?
If they are on the moderate to severe, better to get hospitalized. I think by and large, I think even here they get into the hospital and they will be started on insulin. By and large, hypoxic patients won't be managed at home. That's quite now the awareness is quite high. By and large, very rarely we have seen patients being managed at home with the nurse, wherein the treatment remains almost similar. Insulin, the nurse will be administering the insulin, but most patients get into the hospital with moderate symptoms.
Okay. So even for moderate patients who are on steroids that you recommend them to check and see if they need to be hospitalized, say they are not yet hypoxic, but because their inflammatory markers are high and there are CT changes that this is to prevent hospitalization. So they are put on dexamethasone to prevent further worsening or hospitalizations. In this scenario, do you advise any changes in their diabetic medications to prevent severe hyperglycemia?
I think once they are put on steroids, most diabetics, their glucose shoots up. They end up requiring insulin. And most patients at home will be managing them with premix insulin, which are quite popular in India, with the 30-70 or a 50-50, with a more dosage given split twice daily. Sometimes even a short acting may be given before lunch.
Okay, thank you. The other question, a lot of the questions are about pathophysiology that have come up. I've reserved that for later discussion because we wanted to get more of the practical guidance from both our experts first. Vishakha, with respect to the beta cell dysfunction caused by the COVID, have you seen anything that is causing new onset diabetes in this COVID patients?
So that's the thing, isn't it? Proof in the pudding will be if you're going to get people converted to insulin who were previously not on insulin, or with fairly well-controlled diabetes, not on insulin, now requiring insulin, or those who didn't have diabetes requiring insulin, isn't it? As I said before, our own local data doesn't suggest that. But as I again said, the caveat is it is a very small population. The admission rate within this area compared to, say, Manchester, Birmingham, or London was certainly not anywhere close to that. So I'll wait for data to come out from that. And actually the key thing is the things that we'll be following up is the people that we have seen long-term follow-up. While it may remit after they recover from the infection, the question is long-term, if they have suffered any beta cell damage, will they manifest diabetes at an earlier date? And the parallels I can draw, and this is from my own sort of thinking, is we see patients with gestational diabetes, for example, who have a temporary insulin requiring status due to increased resistance from placental hormones. If we think of COVID as a similar situation of increased insulin resistance due to a triggering factor, will they in the long run, be at higher risk of developing type 2 diabetes? I think only time, and when you do long-term follow-up on a large number of patients, I think you'll be able to pick that up. I know differently people will, depending on the cohort they see, will have different experiences. But again, from my own experience, I haven't seen that. But that's a very small number of people that I'm talking about compared to the thousands of people who've had COVID, really, or more than thousands of people who've had COVID.
Okay.
But again, primary care data, when it comes out in the long run, if we see, when you compare year on year in the incidence of diabetes, if you're going to see following the COVID waves, if you see rising incidence that is out of proportion to what you would expect, then yes, there might well be a correlation. But I'm not, I don't have that any fixed views on that. I'm open to everything at the moment. There is certainly theoretically, yes, of course, that is potential, but whether that bears out, in the actual translation, we don't know yet.
So what we are seeing certainly is transient hyperglycemia, but we don't know if it's permanent.
Yeah. And I think that's where the registry data will come really useful when you look, if the registry data will enroll all patients with diabetes, certainly those who were hospitalized, with COVID who were hospitalized. And then the long-term follow-up of those patients will reveal whether there's a higher than baseline incidence of diabetes in these patients.
And the other, Dr. Bhagesh, this question is more on the metabolic syndrome and obesity related question by Dr. Vasu. Say, can you explain the exponential increase in infections, ICU admissions, and deaths of COVID cases with increased BMI? Do you want to take that?
I think obesity do have a higher risk. That's the one thing. I think among the comorbidities, what they have seen is after hypertension and diabetes, I think obese subjects are the one who are at the higher risk. But we are not as obese as compared to the West India. I think our obesity index is much, much less compared to what you see in Europe or even in the America side. So our main thing, what we are looking into is mainly a diabetes and a hypertension and a comorbidities. I don't think we are looking separately into an obesity because most obese patients here have either diabetes or a hypertension or a associated other comorbid conditions. I don't think separately we have seen somebody who is not diabetic or hypertension having obesity. That I think that segment is we are interested to look at, but most obese patients in India have a diabetes or a hypertension as a comorbidity.
I think that's very relevant, I think, because if you look at you're right, Vagish, the amount of obesity in the Western nations is much higher, but the pathophysiology behind developing cardiovascular and metabolic syndromes in Asian populations, that occurs at a lower BMI than it does in the Western populations. So, at a BMI of 25, which is considered within normal range in the Western countries, is a overweight population for those who are coming from Asian, South Asian backgrounds. So if you were trying to isolate mere numbers of BMI as an influence on COVID mortality in these populations, that will be absorbed in the diabetes and cardiovascular risk, whereas that can pose as a separate risk factor in the Western populations, which is why when you look at the UK data, etc., it will show, higher BMIs at increased risk without the presence of metabolic syndrome, whereas in India that will be subsumed by the metabolic syndrome.
Thank you. Now let's get to the question of the mucormycosis in diabetic patients. Very important given the current context. Dr. Ramesh, do you see any role in any sort of prophylactic antifungal therapy in any of these patients?
I think the best prophylaxis will be to ideal use of a steroid, but I won't put blame entirely on the steroids because we have given steroids in such a high doses for our Graves' ophthalmopathy, rheumatoid arthritis. So many times we have given a high dose of steroids, but we haven't witnessed the mucor to the extent what we are seeing now. I think this is the relation between a mucor and a COVID. Probably the steroid is acting as a fuel rather than the main reason beyond the mucor outbreak what we are seeing. I think we have used steroids so much in our Graves patients. Weekly, we used to give a 500 milligrams of methylpred for 6 weeks. Subsequently, another 250 milligrams for another 6 weeks. Our rheumatology colleagues have used in rheumatoid arthritis, in flares and all, they have used steroids. But we have not seen such an outbreak of mucor. In fact, St. John's recently, our ENT department came out with the data. They had seen around 100 in 10 years, and they have seen close to 90 in past 1 month.
Okay.
Yeah, that's a huge. I think it just can't be explained only on the basis of steroid. Something more than steroid is playing it.
In diabetic patients, obviously, managing their diabetes is crucial. Do you usually have them, if they did have the COVID infection, do you have them send you more information? How are you managing remotely these patients?
Most patients who are stable at home, they monitor their temperature, The most patients now, they have a pulse oximeter and a glucometer also, I think, and a BP, blood pressure monitoring. These they are doing regularly. And if there is any sign where temperature is not coming down, hypoxia setting in less than 94, or sometimes even in elderly, we are taking less than 90 as a significant marker of a hypoxemia, we do recommend them to go to the nearest hospital or come to whichever hospital is recommended. Otherwise, most patients, if they are monitored from the beginning, they are doing well, most patients. The sheer number what we are seeing in India, because our population is huge. See, our population is a huge, even a 1% or a 5%, it turns out into a few lakhs compared to your UK or even America. In fact, if what's the population of UK is almost of Karnataka or Bangalore? Dr. Vishakha?
Vishakha?
Sorry, I
37
lost you.
Karnataka.
Population?
Karnataka. Same 6 lakh.
Crores.
Oh,
6 crores.
almost like a population of a Karnataka. The state we are staying,
Yeah,
it's
yeah.
almost close to the thing. So the sheer numbers is mainly because of our population is quite huge. Even a 1% reflects into the many folds of what we see in Europe or even in America. That's the major sheer number. And also there is a disparity of healthcare system. Healthcare system is more concentrated into the cities compared to the towns or villages. That's the one more disparity we are seeing in India.
The next question, very important next step. Dr. Sanjay Srinivasan asked, have you seen any retinopathy worsening in patients with diabetes and COVID-19? And we are privileged to have Dr. Ramesh Babu here on the panel, who's head of the Department of Ophthalmology at CMC. So Dr. Babu, can you please unmute yourself and speak a little bit about that? Dr. Ramesh Babu? Okay. Probably not here. Okay. So Dr. Ramesh Babu had answered to one of the questions, have you seen worsening retinopathy? And he said no retinopathy, but follow-up is absolutely necessary for a very short term. And then fundus screening during the disease and also his immediate follow-up is sought if not commonly done, is what he's suggesting, and certainly need to evaluate as soon as the crisis is over and they're able to come in, I guess. So Dr. Ramesh Babu, can you hear me? Okay, we will proceed with few more questions, and then we can end the session with a few pearls from our experts. I have a couple of questions that came up after, so it could be in any of the categories. So one of them was about the difference between type 1 and type 2. Vishaka, have you seen worse outcomes with type 1 or type 2 in comparison?
So again, yeah, numbers are vastly different. Obviously, far fewer numbers of patients with type 1 compared to type 2. And so the only data you can turn to is the national data rather than institutional data, because institutional data, the numbers will be very small. And as I said, you know, when they looked at the national data, what they found was a threefold increase in mortality for those with type 1, a threefold odds ratio, essentially, of type 1 deaths, and up from a 1.8 to 2% times for type 2 diabetes. And this is certainly for in-hospital mortality. And similar when you look at the all the sort of reported deaths throughout, there is a higher mortality associated with type 1 compared to type 2, which is higher than those without diabetes in general. But yeah, institution level data, because the number of type 1 patients is so small, you won't be able to tell the difference so easily.
Thank you. And Dr. Vagish, Dr. Sadhna is asking, is Glargine or Lantus affordable in India? If so, ideal starting dose for diabetic patients.
Lantus, original Glargine Lantus is available also. Even the generics are available. So the generics are almost 50% rate of the Glargine, original Glargine Lantus. So we start on the rule of a thumb, mainly based on their fasting plasma glucose. So generally what we do is, for example, in adults with type 2 diabetes, the starting dose will be around 10 to 12 units if their fasting blood glucose is between 180 to 200. Simple is convert milligrams into millimoles, give that much of a dosage. That's what we do it. The reason being, the first when we start, we don't want them to have a hypos. That's the first thing, because that will be a major deterrent for a titration or even a continuation. So we start on a smaller dosage of 10 to 12 units if their fasting is around 180 to 200. Subsequently, I think twice a week or once a week, based on their hyperglycemia, the up titration happens.
Thank you. Thank you very much. So the last topic I have is diet, which is very important in diabetic patients. Vishaka, I'll have you go first. Do you recommend high protein, low carbohydrate type of diet, especially if patients are on multiple medications and have not such a good control of diabetes?
So that very well depends on where they are. Are you talking about general diet? Are you talking for someone who has COVID and what severity of COVID they have? Obviously in patients in ICU and will be parenterally fed for most part. And that will be the mix that's determined by the intestinal failure teams. Generally for other patients, I think again, yes, there is a disproportionate loss of protein, sort of muscle mass in someone who is critically unwell, particularly those who are hospitalized, and even more so for those who are in ICU. So again, the dietitians here who would review would go for a higher protein diet. Remember also, it's not so much sometimes about what is an ideal diet. In some situations, it's just about what you can afford, and that's true even here. In terms of everybody's socioeconomic status is not exactly the same, and I've had patients tell me, yes, you may tell me McDonald's isn't very healthy, but I can fill my stomach for a quarter of the price for the salad that I can buy. So sometimes it's more a function of that. But in all cases, we do say it has to be a balanced diet at the end of the day. So over avoidance of carbs, but not a complete avoidance of carbs, because all you end up doing when you go for a very low carb diet is you end up with a higher ketosis risk essentially, and adversely affecting the lipid profile. But protein, yes, and that's quite easily achievable with Indian diets, even if whether you're vegetarian or non-vegetarian. If you look at the sources of protein we have plenty of sources of protein, whether that's pulses or whether that's meat. That is particularly important for those who are recovering in the recovery phase from a severe COVID illness. But no, I would not go for an extremely low carb diet. That will not be helpful. Though you've got hyperglycemia, remember the glucose is in the blood circulation. It is not in the tissues where it needs to be, essentially. So.
Dr. Vagish, your opinion on that?
Okay, I think especially the part of the India where we practice is predominantly an carb diet. Close to 70% of the nutrition comes from the carbs. Even when we tell reduction in the carb, I think they'll end up having minimum 50%. That's, I think, the general recommendation, what comes from most of the societies. I think our protein intake is less otherwise also. Probably total in India, the protein intake is the one which is quite less in our part, though we tell, but most of the time they lean towards the high carb diet only.
Okay. Thank you. I want to say to our fellow doctors, we are in the process of making a video with the help of a nutritionist. And we will see if we can, share it with you all. It will be done in Kannada, so it can be, shared with all our patients in Karnataka. We will upload that in few days from now. And this is very important. Please take a cue from both the experts about counseling your patients on their diet as well. Although, as Dr. Bagi said, it is challenging with the high carbohydrate diet, mostly the one that's predominantly followed. And with that, I would like to ask I'd like to first of all thank you both so much. We've learned a lot today. I would like to ask each of you to give us few pearls, few take-home message. If you would want us to remember three things from today, what would they be? Vishaka, you want to take that first?
So what I would say is, of course, I think it's probably you've heard hammered on enough about insulin and the management of acutely unwell patients. I would say if you're struggling really with your IV insulin scales, addition of subcut insulin in addition to the IV insulin often works to get the control down a little bit, because the other experience I've had is if you incrementally keep increasing the rates of IV insulin per hour, at one point you reach a plateau, you saturate, you don't really actually get any additional benefit. So going in early with that subcut insulin, and because all that will do is replace some of your basal insulin, you don't have to worry too much about hypoglycemia if something were to happen, but you have to be sensible about the doses that you get. So that's one thing. The second is, again, I would say, as always, sensible use of steroids. I know we have multiple guidelines and multiple different protocols are followed, but as far as possible, especially for the patients with diabetes, has to be a clear risk assessment before you prescribe steroids for them. Is this really going to benefit this patient or not? And then educating them about that risk of hyperglycemia with steroids. And it'll depend on the individual patient's circumstances whether they are able to monitor at home or not with the glucose. And I would say again, the third is I've been taking this as an opportunity to reiterate to all my patients with diabetes the risk that high BMI and poor control of diabetes poses to you. So using this as a long-term educational sort of tool, because this is the first time we have seen people with pure obesity and no other metabolic conditions die of COVID, and younger patients. And so that, is something that, whereas everybody would say only if you had heart disease or if you had really bad diabetes would kill you. But actually, we're seeing patients who have obesity alone, 40 BMI, nothing else wrong with them, 45 years of age, suffering from very, very severe COVID. So using this as sadly, a very heartbreaking way, but it's a great sort of opportunity to push the public health message that at the end of the day, a healthy lifestyle, ideal weight, and regular activity are very important.
Thank you. Dr. Vagish?
I think he's left.
Yeah, I think he's dropped out of this.
Oh, what happened?
No, maybe we
He
can
might
wait
rejoin.
for
Yeah.
Fuzi. Yeah, he might rejoin.
Okay. Dr. Bhagya, can you please text him?
I'll call. Yeah.
Yeah, just see what's going on. We just need few more minutes and we'll be done.
Yeah, but Seema, what are the three takeaway points that you want to put here to summarize the whole discussion?
Okay, so what I mainly one of the things that I got was that especially patients on steroids with diabetes, it is extremely important for them to keep an eye on it, because they may need insulin much earlier than we think that they do, because we're trying to manage them with oral medications, and we just may not be doing all that is possible to do, because that I I see that that is our first step to prevent hyperglycemia and severe outcomes in these patients. And then the other takeaway point is with the, as Dr. Vishaka was talking about, the inpatient protocols with the IV insulin versus the subcut as the main role, and the subcut as the supportive role, and then very close monitoring and parental nutrition support. The third takeaway, what we were all trying to learn with access to the glucometers and how we're going to manage. So likely it's we can get somewhat of an idea, but I don't think it will be easy. Dr. Vagish is here. Welcome back. I will proceed after I speak to Dr. Vagish, Dr. Vasu. Okay.
Yeah.
Dr. Vagish, we will continue where we left off. Can you help us with a few take-home pearls?
Be careful in prescribing steroids to your diabetic patient. If you do so, I think for a frequent monitoring, and also have a low threshold to initiate the insulin. That's the most important. Second thing is regarding a vaccination. There is a lot of doubt. I think we have not come to the vaccination here. Most of my patients they call and ask, so I have uncontrolled glycemia. Should I take a vaccine or not? So I tell that, okay, please go ahead and take. It doesn't harm your glucose, but the protection may not be optimal as expected. But if it is available, go ahead and take at least some amount of immunity conferred to you that will protect you from the illness. I think vaccination, I think we need to propagate this vaccination to a greater extent across that too, especially in our diabetic patient. And any moment you have a features of a hypoxemia, don't delay the admission. I think most deaths, what we are seeing in our hospital is because they come in a hypoxia with saturation of 70s, even after on home oxygen of 5 liters. Many of them have got oxygen concentrators and oxygen cylinders. On that also, that 70-75% they come to hospital, and those are the patients, they are having lots of problems when they get admitted.
Okay. Thank you. Thank you very much for that vaccination PSA, because that's very important. And I would certainly say that that is one of the most important things to combat, especially now to prevent if there is another wave. We have to get everybody vaccinated, and we should not wait for, we should not make the perfect be the enemy of the good. So whatever hopefully they can procure, we should get most of our population vaccinated. Dr. Vasu, I think these were most of what we wanted points to make or questions. Please go ahead, and then we can end the webinar.
Thank you, Seema, and we must thank Seema also for this, because she has done so much of her homework and has spoken to the other organizers, and she has done it quite well. And I thank all of those who could participate in this on a Sunday. And just to remind once more that we are running a helpline from BMC 92, and we request the doctors who have participated in this webinar but still have not registered into our helpline. So please do contact any one of us, and you can be part of our helpline team. Thank you. And we'll be holding these webinars almost, at least during the lockdown time, we'll do it every week. So we request all of you to be part of this initiative. And anyway, Vishaka is very much part of this helpline, but we want to thank Dr. Vagisha here for sharing his experience. And thank you, Vishaka. We'll continue to hold such webinars in future also. Thank you. Thanks a lot.
Thank you for having us. I also have learned a lot.
Thank you, Dr. Seema. Thank you, Dr. Vaishaka. I think your NHS register will be of very use for us. We don't have any such registry in India, though in a small way we are doing it. But I think the long way to go and to get ideas from that registry.
Actually, I think it is international, Vagish. So if you needed to register, it's called COVID Diab. If you search it up, it's run from London, from King's College, but I think it is inviting international participation. So pretty much anybody can, I think, sign up. If you look on the COVID Diab, it's called. Search for it.
Dr. Vishaka, if you could please send that